So sometimes once we've pre-medicated our patient, they're actually sleepy enough to allow a pre-oxygenation without any stress to the patient. Other times though, if the pre-medication is more light, we might actually need to induce anaesthesia before the cat will tolerate a mask for pre-oxygenation. So here is just a demonstration of a low dead space face mask being used to pre-oxygenate this patient. Once we've done our anaesthetic induction, we can test palpebral reflexes and jaw tone and gag reflex, and this will help us to know whether we're at a stage ready to perform the endotracheal intubation. So once we've pre-oxygenated for a little while, we'll take the mask away, and my nurse can pre-oxygenate from the side using flow-by. Normally the patient wouldn't have its jaw open at this point, but we again would test palpebral reflexes, we would test jaw tone, and if the tongue is available, just to pull that slightly and see if there's any gag reflexes there. But once we've got all those reflexes nice and calm and relaxed, we're in a good position now to go ahead with endotracheal intubation. Okay, so once we can pull the tongue forward, we sometimes need a swab to hold that. So I'll just try so we can see. Using the tongue gently to pull forward and also to pull down on the lower jaw, we open up the throat so we can see a little bit more clearly. Then with our laryngoscope, we can use that to depress the base of the tongue, and that helps to flip the epiglottis forward. And then with our non-dominant hand, we can hold both the tongue and the laryngoscope, and then we can see right down onto the glottis. And now we just check we've primed our Intubate, and there's a nice little mist there, and we then spray onto the larynx 1 or 2 sprays. Then we can relax the pressures and re-oxygenate again at this point if we need. And now we need to wait at least 30 seconds if you're impatient like me, and preferably up to 60 or 90 seconds for the effect of that local anaesthetic to work. I think it is important not to be impatient, just to let the local anaesthetic work. Because what we're trying to avoid in cats, they have a much more sensitive larynx than dogs. We're trying to avoid laryngospasm and anything that might make us wish to sort of try and force the endotracheal tube into the larynx, which may cause laryngeal trauma and later edema and so forth. So once we've waited our 60 seconds or so, then we take the oxygen mask away, and again the animal can be pre-oxygenated using flow-by from the side. My assistant again can use her fingers or sometimes a bandage, a tape, to open the jaw by holding behind the maxillary canines. Using a little swab just to help us pull the tongue forward gently, and we can use the tongue to pull down on the bottom jaw, which helps open up the jaw. Using our laryngoscope to depress the base of the tongue to really help flip the epiglottis forward, so we can see now a beautifully relaxed glottis, nice and open. And then with our pre-lubricated tube, we can see beautifully into the airway, no signs of laryngospasm when we tickle the arytenoid or the vocal folds now, and we can then nicely advance that tube in place. And we need the connector of the tube to be roughly around about the incisor arcade. Make sure the tube isn't too long because we don't want to go off into one lung either. And at this point we will then secure our tube in place with a tie. And in cats we usually tie that behind the ears. If they have a long nose, sometimes we'll tie that to the maxilla. And then we can check for position of the tube by connecting to our circuit, and also either a connector that has a side stream, or you can use mainstream capnography, and to a modified T-piece here. If the cat is not breathing at this point because of post-induction apnea, we can deliver a few breaths by hand, and we can check the signal on our capnograph. It may be at this point that we hear some leaks around the endotracheal tube, and we may therefore wish to inflate the cuff, and this helps reduce theatre pollution, and also means that if we need to provide positive pressure ventilation, we can do that in an effective manner. Also, inflating the cuff will help prevent debris or fluids and things going down the animal's airway should we be doing things like dental procedures. So to inflate the cuff safely, it's good to have an assistant gently squeeze on the bag with the valve closed on the anaesthetic system, just as I inflate the cuff slowly with a sort of 2–2.5 ml syringe, and listening all the time for leaks during that inflation. And once I get to the point where I can't hear any more leaks, that's our cuff adequately inflated. We need to be careful with cuffed endotracheal tubes where we inflate the cuff in cats, because they are prone to tracheal damage, particularly dorsal ligamental tears, and that's especially if the cat's going to undergo multiple changes in position, where it's possible that the cat is rotated around the tube. So we need to be careful every time we change the cat's position. We disconnect briefly, move the cat's position and then reconnect. Sometimes we can deflate the cuff in between those position changes if we feel that's safer.